In this PowerPoint, we're going to talk about some of the fungi that can cause disease. So it's pathogenic fungi. Now there are lots of fungus out there, lots of fungi out there. Do great things, help break things down out in the environment, great decomposers, generally don't cause issues. There's over 100,000 species of fungi and less than 200 cause disease. We're going to talk just about some of the most common disease-causing fungus or fungi in this PowerPoint. So we're going to go over what is medical mycology, what are the fungi that are considered true human pathogens, what are the ones that are opportunistic pathogens, and then the ones that most people think of when they think of fungus infections, those ones that are affecting the skin, the hair, the nails, those are the superficial, cutaneous, and subcutaneous mycoses. So first, just what is medical mycology? So anything that has that root word myc, that MYC, is dealing with fungus. Medical mycology is looking specifically at the fungus that causes diseases, so diagnosing them, managing, and hopefully even trying to prevent them. Now we do run into issues with mycoses or disease-causing fungi. They're difficult to diagnose because a lot of the signs and symptoms that they cause are very similar to bacterial and viral diseases. So when patients come in exhibiting specific signs and symptoms, generally we're going to look and make the first assumption that it's some type of bacterial virus before we start to even consider the fungal diseases. And like bacteria, they are becoming resistant to a lot of antifungal drugs that we have. Now, how we get fungal diseases, because there are spores, there are fungi everywhere. We find them in our soil, we find them in the water, we find them in the air, everywhere. The majority of them are picked up through inhalation when we inhale spores. Some are picked up through trauma where they can get into open wounds, and some are picked up via ingestion. Luckily, most are not contagious. Generally, if you pick up a fungal disease, you generally don't spread it to someone else. You would have to pick it up directly from the source, not from another infected individual. The exception to that are some of the ones that grow and survive on the skin, that skin-to-skin contact can spread them. We do have, though, cases where we have epidemics, meaning a large group of individuals all become infected, and it's not because they were spreading it among those individuals, it just means they were all exposed at the exact same time and place. This can happen if you get fungal spores, say in air conditioning vents, somewhere in the building, that everyone in that building all breathes in those spores, all gets infected with the fungus, all has the disease, but it's not because they spread it person to person. A lot of fungal diseases are also not reportable to the CDC, which means we're not really tracking them all that much. So we're not tracking to see where do we see a lot of the cases, how often are we seeing the cases, are we seeing large increases or even slight increases in cases, just because it's not required to be reportable, so a lot of hospitals don't report. Now the true fungal pathogens, there's only 4, and what it means to be a true fungal pathogens is that they can cause disease even in the healthiest of individuals. So it's not something where okay, you have to be elderly immunocompromised to suffer from these. It's just the healthiest individuals can pick up these. Unfortunate for us, they are endemic to the Americas, so North America and South America. The opportunistic fungi, these are the ones that usually you have to have some type of issue going on. So you're immune suppressed, elderly, examples of things that put you at increased risk if you've had some type of medical procedure, again, that puts you at increased risk of bacterial infections as well as fungi. If you're on immunosuppressants, cancer treatments, if you have some other type of disease that may be affecting immune system, and even lifestyle factors can put you at an increased risk. Now, how many spores get in the body combined with what your immune system status is, how good is it, depends on how severe that fungal disease is. If you have a low spore dose that gets in your body and you have a great immune system, you might not even have any signs and symptoms, or they're going to be very slight. Whereas someone that gets a large dose plus is immunocompromised is going to suffer more severe and higher level signs and symptoms. Now, diagnosing someone that has a fungal disease, one of the most important things they can do is looking at patient history. Again, have you traveled somewhere that some of these fungal spores are found? Because again, a lot of the signs and symptoms, they're immediately going to think bacterial or viral. They're going to start testing bacterial and viruses before they even start testing for fungi. So mycosis, those fungal pathogens generally are not routinely tested. We don't have those quick tests like strep tests to do it. Some of the ways they do test, they can grow the fungus. Usually this is if it's one on your skin. They can take a skin scraping and they can look to see are there any fungal spores that are growing on your skin. We do have selective plates, the Sabarod agar, that inhibits bacterial growth because we know we've got bacteria on the skin. But the only thing that is going to grow is fungus. So it's one way to really know if there are fungal spores living and thriving on your skin. Other techniques, they can look for the cells themselves in that skin scraping. Instead of waiting for this to grow up, they can dissolve the keratin, aka they're going to dissolve the skin cells, and then they can look directly for the fungal cells. Another way they can confirm, because just seeing spores underneath a microscope is not always going to tell us what it is. We do have a lot of DNA testing as well. Treatment. Problem with medical mycoses is a fungus is still a eukaryotic organism. Our cells are eukaryotic cells, which unfortunately means they share a lot of characteristics. So drugs that target these fungi have to target the uniqueness of a fungal cell compared to the uniqueness of our cells. Now, these fungal cells are becoming resistant to our immune system. And because they are so similar, just that eukaryotic nature, when we do take antifungals, these antifungals, if given at higher doses, can cause side effects. They can start to harm healthy cells as well. And so usually antifungals are given low dose for a long period of time to try to decrease any of those side effects that are going to occur. One of the most common antifungals that's given is ergosterol. Is amphotericin B, and how amphotericin B works is it targets ergosterol. So here's a cell membrane. Our cells have cell membranes, fungal cells have cell membranes. And one of the structures in a cell membrane of a fungus is ergosterol. And amphotericin B recognizes ergosterol, and anywhere it sees this ergosterol structure, it inserts a pore or an opening. So it's creating holes in a cell membrane where there shouldn't be holes, which means stuff's going to get in that shouldn't, stuff's going to get out that shouldn't, and ultimately the cell will die. Now, amphotericin B works great. It's our gold standard antifungal. The problem is our cell membranes have something in them that it's not ergosterol, that is unique to fungus, but our cell membranes have cholesterol inserted into them. And cholesterol can sometimes look a little too similar to ergosterol for amphotericin B, and it will insert these pores or channels into our cell membranes, which again then causes harm to our healthy cells. So for those that are suffering from fungal diseases, again, depending on the severity, it's usually a two-step treatment. It's a high dose of antifungal for a very short period of time to decrease the number of fungal spores, and then a low dose to try to prevent any new infections, kind of trying to keep that fungal disease under control, hoping the immune system is going to rid the body of the remaining. Now, amphotericin B, sorry, this came up separate. Amphotericin B sometimes does get the nickname of amphoterrible just because it can recognize that ergosterol and insert pores, and it can cause some toxic side effects. Now, it would be great if we had as many vaccines against antifungals as we do for vaccines against bacteria and viruses, but problem is you have to target these fungal cells and change them so that they can't cause disease, and the cells are very similar to ours, and it makes developing a vaccine safely more difficult. Now, we do have some attenuated weakened vaccines. Again, that means that there are still alive fungal spore, but we've modified them that they can cause disease against coccidioids, blastomycosis, and some strains of candida. They're not routinely given. It usually is at certain individuals that are at high risk, and it's usually multiple doses of the vaccines. Now the true pathogens, so again, these are the ones that it doesn't matter how healthy you are, you could still suffer from these, are Histoplasma, blastomyces, coccidioids, and paracoccidioids. They are all picked up through inhalation, so breathing in the spores. They're all going to first target that pulmonary system because they're going right into the lungs. They cause a pulmonary infection. They can spread through the blood and then get out to the body and cause secondary infections. And all 4 of these are considered dimorphic, which means they grow and reproduce in different ways, whether they're in the environment or whether they're in the human body. And it's temperature dependent. If these spores, these fungi, are in the human body, they reproduce by budding, what we've seen like those candida can do in the lab. Out in the environment, though, they don't reproduce by budding. They form these long hyphae, almost like branches, and then it's off the ends of the branches that new spores are formed. Again, this happens at a cooler temperature, so less than body temperature. And so depending on where these fungi are, depends a little bit on how they reproduce. The first of the true pathogens that causes disease, and is usually the more common one of them, is Histoplasma capsulatum, which causes histoplasmosis. It's generally found in moist soils, usually with a high nitrogen content. And usually the high nitrogen is from bird and bat droppings. So if there are buildings that have lots of birds that are nesting on roofs near air conditioning vents, if people go caving and there's lots of bats and they can breathe it in, it puts you at an increased risk. Again, all of these true pathogens are picked up through inhalation. They can get into the lungs. They're spread by both blood and lymph. And one of their biggest virulence factors is that they can avoid phagocytosis. So it means our immune system cells, as they try to get rid of them, our white blood cells, our phagocytes, can't break them down. Now, where we find cases, the highest number of cases of histoplasmosis, again, we find a lot of them in North and South America, some in Africa as well. And then I always ask the question, I was like, okay, so is it found here? And just based on the picture, you're like, no, but we do have cases here, but the highest numbers of cases are a little farther south of here, but not too far away from where we are. There are about 10 cases a year in Wisconsin. So it's around, it's in lower numbers, but if you head south, Iowa, Illinois, your chances of those cases, the chances of you picking it up increases. Now, what it can cause, 95% of individuals are asymptomatic. Again, this fungal spore is out there, we breathe it in. It can get in, it can cause pulmonary infections, but a lot of times I'm like, it's so minor that it's asymptomatic. Doesn't mean it's not growing in you, but it's very, very minor. If you now suffer signs and symptoms, you have clinical histoplasmosis, aka you're going to go into the clinical. The most likely of the different types of diseases or outcomes is chronic pulmonary histoplasmosis, which again, it's a respiratory issue. It's affecting those lungs. It's going to cause severe coughing, blood-tinged sputum, so you're coughing blood, night sweats, weight loss. And the biggest issue when you come to the clinic presenting with symptoms of severe coughing, blood-tinged sputums, night sweats, and weight loss, immediately they're going to think tuberculosis, because really those are the same signs and symptoms of tuberculosis. Difference though, tuberculosis can spread and they're going to isolate you, whereas this cannot. Even though you're coughing, you are not coughing spores and infecting other individuals. So you don't need the isolation. Unfortunately, as they're testing you for TB, they're not testing you for histoplasmosis. So this becomes important where you're like, hey, I've been, traveling, I've been to these areas, I've been hiking, maybe I've gone into caves, I'm like, all of those things that may point to this disease versus another disease. If it gets into the bloodstream and the lymphatic system, again, it can travel, it can go out, and it can cause cutaneous histoplasmosis. Now it's going to affect the skin, and it's going to cause skin lesions. It can cause systemic histoplasmosis. This is when it's going to affect other body systems. Usually this only occurs in those that have the weakest immune systems, almost to the point they don't have an immune system, so AIDS stage of HIV infection. It likes to target the liver, the spleen. It can be fatal. Ocular histoplasmosis, as those fungal spores are traveling around in the body, they can get into the eyes. So when the eye doctor looks at the back of their eyes, when they dilate your eyes, they normally see, kind of this is the back of your eyes, but here we can actually see some fungus growing as well at the back of your eyes. It can cause inflammation, it can cause redness. Again, it's treatable and usually heals back on its own. Diagnosing it, a lot of times they're going to look at the actual yeast itself. Depending where they're getting their sample, they're going to look for the spores, some of the budding that's coming off with the spores. Treatment, if healthy, it can go away on its own. If you've got pulmonary histoplasmosis, but maybe minor, where you don't even go to the clinic, it can go away on its own. It might be more of a minor cough. Otherwise, treatments, amphotericin B, that gold standard, or ketoconazole, which is not as strong, and so if you have more of mild symptoms, they're going to give you an antifungal that causes less side effects. Our second of our systemic mycosis, our true pathogen mycoses, is blastomyces dermatitis, which can cause blastomycosis. It is found in the southeastern parts of the United States, all the way into the northern states, up into Canada. Yes, this is definitely found in our area. It also grows in rich organic soils, and we again pick it up because if we're out hiking, kicking dirt up, we breathe in those fungal spores. It doesn't take very many spores to produce the disease. The most common result is the pulmonary blastomycosis, because again, you're breathing in those spores. It affects the lungs for many individuals, asymptomatic or a weak infection. That maybe it's just a minor cough. However, it can last for a long time, so it now becomes a chronic cough. It may resemble pneumonia type symptoms. It also can resemble tuberculosis. It can cause weight loss, fever, night sweats as well. For a lot of individuals, if you're healthy, it eventually can go away on its own, but it can take weeks, if not months. And if you have the weakest of the immune system, so again, those that are severely immunocompromised or in the AIDS stage of HIV infection, it can cause respiratory failure and death. So the most common, pulmonary, again, it could be asymptomatic all the way to chronic, kind of more of a tuberculosis type symptoms. To diagnose, a lot of times they'll do an x-ray and they can actually see the fungus growing in your lungs. It again can get into the blood supply, it can get into the lymphatic system, it can spread, it can cause cutaneous blastomycosis, where it develops into wart-like lesions, usually on your face, which is an unfortunate place, and your upper body. It can get into the bones, and it can cause osteoarticular blastomycosis, and it grows in around the bones and the tissue around the joints. It can also get into the central nervous system. It can cause meningitis. Usually, again, those that are in the more immunocompromised individuals suffer the more extreme diseases. Diagnosing it, they're going to look specifically for those fungus and fungal spores. Depending on the outward signs and symptoms, they can get samples to test, either cerebrospinal fluid if it's meningitis, they can do skin scrapings, they can do sputum samples, again, trying to isolate if there are fungal spores there. Treatment, amphotericin B or itraconazole. Again, these treatments, any antifungals given for a long period of time. Amphotericin B is usually given for 2 to 3 months. Itraconazole is a weaker antifungal, but again, less signs and symptoms, but that also means you're taking it for a longer period of time, like 3 to 6 months. So antibiotics, taking it for 10 days is no biggie compared to antifungals where you're taking it for months. Our third of our true pathogens is coccidioides immitis. which causes coccidiomycosis. You know, we're getting some of these super big words. If you're loving Scrabble, these are great words for Scrabble. Found in the southwestern United States as well as northern Mexico. It's usually found more in desert regions, so desert soil, rodent burrows, mine sites. Again, picked up through inhalation. Once picked up, that spore gets in the lung tissue and it makes this kind of protective shell around it known as a spherule. And then it grows and reproduces lots and lots of spores. Eventually they will burst and then can spread and cause more infections in the respiratory tract. Kind of showing an area's endemic of where they are. This was that case study that, yes, traveling in this area of the United States, if you're going out, you're going hiking, you're out there in nature, you are more likely to pick it up. It's very, very common. A lot of times it's more known as desert fever. Just, you know, they just call it that. And one of the main symptoms is a fever. Your immune system's under attack, you're fever, fatigued. It can cause a rash. If left untreated, more immunocompromised causes the more severe signs and symptoms. Again, most common pulmonary conditions, it spreads only if more immunocompromised. So elderly, severely elderly, immunocompromised, it can spread and it can cause lesions on the skin. To diagnose, they can take a sputum sample and look for those spherules. They do actually have a coccidion skin test, just like a TB test. They have a skin test for this that can help confirm it, as well as doing different types of genetics and antibody tests. Treatment, amphotericin B, as well as a few other weaker antifungals. Again, weaker antifungals may have less severe symptoms of the drug, but usually given for a longer period of time. And then our fourth of our true pathogens, and probably the biggest word, it's the fungus called Paracoccidioides brasiliensis, which causes paracoccidiomycosis. Luckily, we're fortunate it's not found here in Wisconsin, but it's found in southern Mexico as well as regions of South America. So if you have patients that are traveling, again, it's talking to patients and finding past history and what have they been up to, just in there as you're trying to strike up a conversation becomes a big clue for some of these. Farm workers seem to be the highest endemic population that picks it up. They're the ones that are out there digging in the soil, you know, churning up that soil and then breathing it in. Because it is picked up through inhalation, pulmonary condition is the most common. Usually is cough, fever, you know, malaise, feeling tired, your immune system's under attack. It does usually spread from the lungs. And it can cause inflammatory disease of the mucous membranes, so it can cause lesions on the tongue, the lips, the gums that can last for weeks to months. Diagnosing it is looking specifically for the unique budding pattern of the spores themselves. They call it what looks like a steering wheel and then has buds coming off of it. So it's a little bit more unique looking fungus when you're trying to ID underneath the microscope. Treatment, you could probably guess, amphotericin B, one of the top ones, otherwise ketoconazole, itraconazole, and we've got other antifungals as well. The weaker the antifungal, the longer that you are taking that antifungal. Now on to our opportunistic fungi. So these are the ones, they can affect full body systems, so they're systemic, but these really depend on what is the immune system status of the individual. Healthy individuals usually either don't suffer from them at all or they suffer very minor, versus poor immunity, immunocompromised are going to suffer the worst complications. If you have a patient that's severely immunocompromised or in the AIDS stage of HIV infection, they're always going to be the ones that are at the highest risk of picking up these different opportunistic fungi and suffering the worst complications that come from it. They're difficult to ID because, again, the symptoms can be atypical and unusual. They don't all present as the same symptoms. And again, immune system status also changes how those symptoms present themselves. The 4 genera that are routinely encountered that are opportunistic: Pneumocystis, Candida, Aspergillus, and Cryptococcus, which are the next fungus that we're going to talk about. So the first one, the Pneumocystis that causes the most issues for humans, is Pneumocystis jirovecii. It's an intracellular parasite that it actually behaves more like a protozoan parasite than it does a fungus. So it likes to get inside of our cells, it kind of feeds off of them, and then it eventually kills them. It's a fungus, it's not a protozoan. It's still picked up through inhalation, as most of these are. Healthy individuals, generally asymptomatic, so our immune system can get rid of them. Those that are severely immunocompromised suffer the most severe complications. If it's untreated, if you have no immune system, such as AIDS patients, it will imminently eventually cause death. How they diagnose it, just because of that, it's destroying the lung tissue because it's that parasite. How they generally diagnose it: chest x-rays, they can stain fluid from the lungs to eventually identify it. We also, again, have various types of immune system type tests, antibody tests, as well as DNA tests. Treatment: trimethoprim and sulfanilamide, which are not antifungals. They're actually antiprotozoans. Because this particular fungus acts more like a protozoan, a parasite, than it does a fungus, the treatments are actually work best by giving it antiprotozoan drugs. Our second of our opportunistic pathogens is Candida. Now, there are a variety of Candida species. There are a lot of different Candidas out there. The most common one we see in humans is Candida albicans, and that's because for a lot of individuals it's the normal flora of the reproductive and digestive tracts, which is why we talked about it when we did that teeth scraping, because for some individuals it's found in part of their digestive tract, including the mouth. It can be transmitted between individuals by contact, and it can cause a wide range of diseases depending on location, depending on the immune system health. It can cause more severe systemic diseases in highly immunocompromised individuals, and again, especially those that have AIDS. Now, Candida, because it is a yeast, it's a fast-growing fungus, one of the biggest concerns we have are with diabetics. Diabetics are, in those that are not controlling their diabetes, have a much larger number of yeast cells in their body. So if it's part of the normal flora, those yeast cells are at a much higher level, and they are much more likely to cause yeast infections, causing damage. The main reason for that, if you have uncontrolled diabetes, that means you have a high sugar level in your blood. You have a high sugar level in your body, and these yeast feed on that sugar. So really making sure, you're monitoring diabetics, that they're controlling those blood sugar levels, because they are at a much higher level or risk of having some type of yeast infection, and it's usually from some type of Candida species. Now, depending on where the Candida are growing kind of uncontrolled, usually in more immunocompromised patients, kind of depends on what type of candidiasis diseese you have. Esophageal, because again, it can grow in that throat and it can grow uncontrolled. Oropharyngeal, which is probably one of the most common yeast infections. It's more commonly known as thrush. It's not uncommon for people that take immunosuppressants, that if that yeast was part of their normal flora in their mouth and now you are taking an immunosuppressant, your immune system's not keeping the yeast under control anymore. And so it will grow unchecked in your mouth, causing now an infection. Diaper rash, it is very common. Again, a diaper is a warm, moist environment, and these fungi can grow. It can also get underneath the nails, as well as some of the other fungi that can as well. Aspergillus is found out in the environment. We can find it in soil, in food, in compost. It's found in agricultural buildings, on farms. We can sometimes get it into air vents in homes. It's picked up through inhalation, as again, most of these are. The top thing that Aspergillus causes are allergies. That is the most usual result. However, it can be more severe if more immunocompromised, and it can cause different pulmonary diseases depending on how immunocompromised. So the 3 pulmonary diseases that it can cause, and that's if it stays in the lungs, hypersensitivity aspergillosis, this is more of your asthma allergy type symptoms. So your coughing, runny eyes, sneezing, that's affecting the respiratory tract. Your respiratory tract's trying to get rid of something that's irritating it. Non-invasive aspergillomas is when this particular fungus grows in cavities left behind from a past tuberculosis infection. So when patients have had tuberculosis and it's caused those big growths in the lungs, once the tuberculosis heals, goes away, you're still left with empty cavities in your lung tissue, and this particular fungal spore likes to make itself at home. And now it's called non-invasive because it will make itself at home in these cavities and then it will stay there. It's when it leaves the cavities and starts to affect other lung areas. Now we call it invasive pulmonary aspergillosis. Now this can then start to present symptoms similar to tuberculosis. That if you've had a past infection and now you've got very similar symptoms, but you don't think you've been exposed to tuberculosis, again, you can be having chronic cough, blood-tinged sputum, and pain. It may look like pneumonia. Again, they're going to think, oh, well, we just didn't get rid of the tuberculosis, and they'll give you more antibiotics. And again, it's still not going to do anything for this fungus. So it's one of the things that it could be a fungal infection that follows a tuberculosis infection. It can spread. It usually doesn't. But it can usually for the highest severely immunocompromised. So it can get into the bloodstream. It can leave the lung tissue, get into the bloodstream. It can grow then kind of anywhere it ends up. So you can have cutaneous growth. And so we can actually see a little aspergilloma, which that's a little growth, but now it's underneath the skin. It can then go out and affect other major organ systems. Again, usually those that have no working immune system. Before AIDS, when we're talking AIDS patients, AIDS stage of HIV infection, that you're going to get cutaneous and systemic. Treatment, remove infected tissue to try to get rid of the largest amount of the fungus, and amphotericin B, some type of antifungal. And then our fourth of our opportunistic fungi is Cryptococcus neoformans, causes cryptococcosis. We again inhale it, but this is usually more tied to spores that come from bird droppings. So if you're working in buildings where birds, again, are roosting near air intakes, this puts you at an increased risk. Its main virulence factor, it has a very thick capsule, so it's resistant to phagocytosis. And it usually will cause primary pulmonary cryptococcus, which is usually just more of asymptomatic to mild pneumonia. So a low-grade fever, a chronic cough. Again, some individuals wouldn't even go in and get tested for it at that point. The more immunocompromised you are, the more likely, again, you are to suffer more severe complications. It can get into the it can get into the cerebrospinal fluid and can cause meningitis. Again, this is usually when you're going to go in, you're suffering the worst, that you would go in and get tested, and usually those that are the most severely immunocompromised. It can spread and cause ulcerated skin lesions. Eventually they can go away on their own, but again, that in itself will probably send you to the doctor to get tested. Once tested and diagnosed, some type of amphotericin B or other antifungals that we've got on the market. Now, I have mentioned AIDS patients a lot. Again, if you are in the age stage of HIV infection, that means you have a permanent immune dysfunction. Your immune system's not going to get better. Your immune system can't do the job that it was supposed to. And there is no cure then for these antifungals. These antifungals work by trying to kill the fungus, but you're expecting your immune system to get rid of any remaining. Kind of the two together, the drug plus your immune system. But if you have no working immune system and it's not coming back, there really is no cure. So most patients, if they are in the AIDS stage of HIV, are usually on antifungals for their entire life, because mycoses, fungal diseases, cause the most deaths associated with AIDS. Even certain fungal infections diagnosed or defined end-stage AIDS, because even if you have a slightest working immune system, that along coupled with some type of antifungal should make a lot of these different diseases go away. But if you're in the AIDS stage and have no working immune system, we can now diagnose that you're in this end stage. There's a couple new fungal pathogens that are generally only affecting those with no working immune system. Some Fusarium species, some Penicillium species. There's a lot of Penicillium species, as well as a trichosporin as well. So new fungal diseases that are affecting those with no immune system. And then the very last group of fungal diseases, and these are the most commonly reported, and it's because they're so visual, these are the ones that are living on your skin, hair, and nails. They are opportunistic, which usually means they're growing somewhere where they're not supposed to be, or if you have a weaker immune system, you're more likely to pick up a fungal disease. They're usually localized, which means that fungus is growing at the site that it was picked up and is usually near the surface of it. The infections are usually localized, which means they're growing uncontrolled, usually at the sites where they're picked up. How they're picked up, some type of environmental exposure, some touching inanimate objects that might be infected with the spores, but they can be spread person to person, so skin-to-skin contact. They're not life-threatening, they're not affecting major body systems. You may feel like you're going to die because you have this horrible-looking fungal disease, but they are usually chronic infections, which means that if you've been infected once, even if you took an antifungal and it went away, you are more likely to have it show up again. The dermatophytoses, these are dermatophytes. So specifically, these are ones that are growing on your skin, your nails, and your hair. Some of them are part of your normal flora. Some of them can cause disease, again, if left unchecked. Depending on the disease they cause and where they're growing, they can cause a condition known as tinea, or more commonly known as ringworm, which means the fungus is growing on the skin, and wherever the fungal spore initiates, it will grow, it will cause inflammation on the skin, and as it is growing and spreading outward, it causes inflammation at that actively growing outer area, causing that circle, that ring. So if it grows out in equal distance on all sides, it forms a nice perfect circle. There is no worm, but at one point they really did think, because of that shape, that there was a worm underneath the skin. There is not. It is a fungal disease. It again lives on your skin and your nails and your hair, and it can feed on the dead tissue, and it can feed on the keratin protein that's found in those cells. It may trigger your immune system response that's going to cause the inflammation, and it can be spread person to person. Wrestlers are a big group it's a big sport where they could be spreading this fungal disease. And that's just because of that skin-to-skin contact, as well as usually wrestlers are sweating, so there's a warm, moist environment. A lot of times wrestlers even have their wrestling practices in a very warm environment, so that they purposely do sweat for losing weight and making weight, which again makes a fungus breeding ground. Another skin fungus that grows on the skin is Malassezia furfur. It's for a lot of individuals, part of their normal skin flora. What it can cause, though, is a condition known as pityriasis, which is either a depigmentation or a hyperpigmentation in patches. Kind of wherever it's growing, it can cause this depigmentation, or it can cause more of a dark patches to grow. Diagnosing it, they can do a skin scraping right at those infection sites. They can look for the budding yeast, sometimes even some short hyphae, and diagnose it. It's not causing any harm. If it's just a superficial infection, it's just a little bit that's annoying, there are topical antifungals that can kill it and make it go away. If it's a pretty extensive growth, there are some oral antifungals that you could be given. The problem is it's part of your normal flora. Even if you got rid of it, apparently you have a wonderful environment for it to grow in, and you're more likely to pick it up and have it again. It is most commonly diagnosed and treated in the summer, and even based on this picture on the individual, it's because a lot of times if it's causing a depigmentation, we don't even know in the winter months if you're getting paler, because you're as pale as you possibly can get. But in the summer months, when your skin tans and now you notice areas that aren't, this is usually when you go in and get diagnosed. There's some of that spores and short hyphae. Another of our fungal diseases is Sporothrix-Schenkii. This is found in soil and plant materials. It usually will cause infections on the arms and legs. This fungus has to get into scratches or abrasions. It has to get into an open wound. And those that grow roses usually are at the highest risk, because as they're working with roses, they're working with soil and plant material, and the roses have thorns, which cause those abrasions, and now there's that open site for them to get in. It usually first causes lesions at the infection site, so it's going to cause the damage right where it gets in, but it does then like to get into the lymphatic system, and then as it travels through the lymphatic system in those arms and legs, it causes lesions. So here is probably that initial infection site. It gets into the lymphatic system, and it causes secondary lesions along the lymphatic vessels. Generally doesn't cause any other severe complications. Beyond that, it's just more of unsightly, painful lesions along your arms and legs. Diagnosing it, again, they can look for the dimorphic fungi. They can just look outwardly at the lesions of your skin, talk with the patient past history, what have they been up to. Treatments, we've got topical antifungals that can be given. If it's bad enough, we have oral antifungals as well. Best prevention, making sure if you are working with soil and something that may scratch, having long clothing, gloves on just to protect your skin. Now, other than very specific diseases where this fungus is growing in your body causing different issues, fungi themselves, as we breathe in spores, are a cause of a lot of allergens. You know, a lot of times on the news you may even see it, well, here's our allergy report, and they'll specifically talk about spores or fungal spores. So we can find fungal spores inside in our houses, we can find them outside, you know, and it can be up to 10% of individuals have allergies specific to fungal spores. Generally what it causes is type 1 hypersensitivity. It's your basic allergies. Is asthma type symptoms, maybe eczema, hay fever symptoms, that watery eye, runny nose. That's typically what it is. Occasionally it can cause type 3 hypersensitivity. This is when you're going to have more severe complications. It's usually from chronic nonstop inhalation of certain fungal allergens, more commonly like in farmers that are constantly breathing these in. It can cause more severe immune system reactions. And then the last couple slides I have on there, these aren't diseases caused by mushrooms, but they can kill you. So these are not, none of them are ones we breathe in. These are all mushrooms that we eat that can then kill us. So mushroom poisoning. So the very first one, Amanita phalloides, is known as the death cap mushroom. And if you eat the death cap mushroom, because of the toxins that this mushroom has, it will cause liver failure and ultimately death. The Gyrometra esculenta is known as the false morel. So if anyone's ever gone morel hunting, morel should look like this. Should be tan. They have this nice honeycomb look to it, and they are hollow inside. That's the biggest clue. Hollow inside is normal. A false morel still kind of looks mottled at the top, kind of almost getting to a honeycomb looking, but it's going to be darker and solid inside. But for someone that doesn't know that these exist, they may just think it's a really funky looking morel. Well, this false morel, if eaten because of the toxins, can cause bloody diarrhea, convulsions, and death within 2 days of eating it. So only eat the ones that are hollow and tan. The last of the ones that can kill you is Cortinarius gentilis. It will cause excessive thirst, nausea, and full-on kidney failure. And again, it's the toxins that they make that are causing so much imminent damage. The last two of mushroom poisoning, again, these are all fungi that you can eat. These two don't kill you, but they can still cause issues with patients that can then bring them in to the emergency room and then become your patients. It's the Psilocybe cubensis and Amanita muscaria. Both of these are ones that can produce hallucinations and convulsions. So it's the hallucinations is why individuals usually eat these two particular mushrooms. These are the ones that when they talk about individuals that are shrooming, these are the ones that they are talking about. Now, because if you ingest enough of them, they can cause convulsions and they can cause some kind of bad side effects, individuals may come in to the hospital to get treated. Usually it's inducing vomiting to get that fungus out of the body, activated charcoal to absorb toxins. If eaten enough and for a long period, it can cause liver damage. And depending on how severe, it may even require liver transplant. Now, the interesting factoid about the Amanita muscaria is kind of the story goes, this is a red mushroom with little white spots all over it, is that someone that was ingesting this particular mushroom was hallucinating and hallucinated and saw an individual, a male, that was wearing lots of red, that was rimmed in white fur. Or the story goes, someone that was shrooming saw and kind of made up the story of Santa. So when it comes to Christmas time, it's a kind of a fun factoid of where did that whole idea of Santa come from? One of the story goes is it came from someone that was shrooming. And actually you can see it at Christmas time. This mushroom is incorporated more often than you think in various Christmas areas. And you're like, oh, well, it's red and white because it's kind of Christmassy with its red look. But actually it does stem back to this is a mushroom that causes hallucinations. And yes, it may also have caused Santa to originate. So kind of fun factoid to leave with you here at the end.